Another interesting thing that came up was a patient of mine, a very sick gentleman, got discharged from the hospital, and post-discharge, that means after the discharge, the patient, actually two or three patients got discharged. One was after surgery, the other one had infection due to his overall sick status, and he had infection in his urine. Much older gentleman, so he was discharged, and we were trying to look at their medications. And a lot of times, what we're seeing is this is the most confusing part after getting discharged from the hospital, as in what medications have changed and what they should continue with, what they shouldn't continue with, and what should be done about this, and how soon would you need to go back on the medications you were on, and why has everything changed, and if you were discharged to a rehab center to recover where you needed inpatient physical therapy, and then your medication are further changed, and now you're at the doctor's office for trying to get back to normal, and half your medications are different. Very confusing because there's a set of medications that you are supposed to be taking as prescribed your doctor in the community. And that might include some specialists, but your primary doctor should be taking all these things into account. And then you go to the hospital, certain medications are stopped right off the bat. Other medications may get stopped as your stay in the hospital progresses. And then they might give you alternate medications in the hospital, because the hospital usually will have its own pharmacy that they use, so they may not carry the same brand or the same medication, but they might switch it to a different kind. A good example is insulin. The hospital will carry one or two kinds of insulins. As an outpatient, you might be on one of the 6 or 7 different kinds. So they will switch that. Sometimes people who have diabetes but are not on insulin get started on insulin at the hospital, and they will usually come and say, like, oh, they were giving me insulin in the hospital, I don't even know why. And then when they're coming out, they are discharged with the medications that the hospital was giving them, because the doctor over there is going by the medications that you are taking and what has been working, and as of the day of discharge, what is the list of medications you're on and what they would like to continue. But almost all the time, including myself, if I'm discharging a patient from the hospital, we will reconcile the medication list, that which ones we can stop. They were being given in the hospital, but now it's okay to stop. Which medications need to be resumed that were stopped at the time of admission or during the hospitalization. Which ones can we bring back? Based on those, the list is done, and it can look significantly different from the list you had prior to going to the hospital. And then if you were, I'm going to add, like, if you go to subacute rehab after surgery or after a prolonged sickness, that you're better and don't need hospital inpatient care, but you still need physical therapy and some nursing care, and you go to a skilled nursing facility, post-acute rehab, subacute rehab, many names for that, but basically if you're not going home and you're going to a step-down facility where you still need to continue taking the medications and get some physical therapy, get back on your feet. So over there, they have their own pharmacy. So now they will take your medications from the hospital and change them to what their pharmacy has. And now the names are again changed. And then by the time you are discharged and go back to your doctor, everything looks, everything is turned 180. in all good faith, the doctors have reconciled the medications that this is what you should be taking, but they are different. And then when you go to pick up those medications from the pharmacy after you're discharged, your insurance says like, oh, this is not covered, and that is not covered, and you can't be on this, and you can't be on that. So, and then you go back to your primary doctor, and he looks at all the medications, and he or she are expected to bring you back to the medications that you should be taking, that you were taking, which ones are now new, and which ones have changed, and which ones are stopped, and which ones your insurance will cover. So putting all this together, it's like the reconciliation happens multiple times, and which ones can be resumed at a slightly later date. And unfortunately, the system is pretty messed up, and it does not allow you the full access to what really happened. So what's wrong here and what's right here? So what's wrong is that this becomes more confusing than ever, and especially the instructions that are handed out to patients are even more confusing because they're just printed at the time of what was going on in the hospital, and if a medication was changed, the computer is reading this as stop and start that one. So now we read this as, oh, he doesn't want me to take this medicine, but now my primary care wants me to take it again. I don't know who to trust. I saw the cardiologist and the neurologist over there, so maybe they're right, but my primary care was not there. So, and he's changing them. He's told me to stop this medicine. So what do we do? First of all, understand that the medications that you're on at that given point are supposed to be most appropriate medications for you under those circumstances. So when you are perfectly healthy, or in stable condition, and things are being managed at home, you're on a list of medications that is, oh, these are for your diabetes, these are for your cholesterol, these are for your blood pressure, this is for your heart, this is for your lungs, and so on and so forth. And everything is taken into account, which is how to most appropriately manage your conditions. When you go to the hospital, things are different. You're not stable. You're not being managed in the way how you were, because your status has changed. That's why you're at the hospital. So obviously, you get blood work, you get scans, you get a different formulary. So medications may be stopped, and a lot of times they're held. That means we're stopping it for now. We might consider resuming it later. And so your list may drop from 10 medications to only 5. The 5 are held, not necessarily stopped, unless there's an obvious reason that they should be stopped and never started again. But for the most part, they are held for a certain amount of time, which is decided by your primary doctor when you return from the hospitalization, so that they can find the perfect time based on what happened, what's going on, and when to get back on the same medications. Secondly, a lot of medications will change names. The classes of the medications, the job that they do, the purpose of the medication doesn't change. So you were on 2 medications for high blood pressure, let's say losartan and metoprolol. These are 2 common medications prescribed for high blood pressure. And in the hospital, they don't carry. So for them, these 2 classes of drugs may be different. So they might just change the losartan to valsartan, and the metoprolol to carvedilol or atenolol. And then, so from your perspective, your medications have been stopped and you've been put on different medications, But from my perspective, when you're back, I see that you're on the same medications, same class of medications, but they chose to, they were changed to availability and their needs, and whether they could better control them, or they felt that this was slightly better than the other, or that's what they had, which is basically their formulary. So technically, these medicines have not changed. Diabetes, you started with like 3 medications that we were on before. They stopped 2 of them. 1 was resumed, and the other 2 were not restarted. But then again, the reason might be that they leave it up to your primary care doctor, to see what's the best time to go back on them, or not. But it's for them to decide. The hospitals are only looking at that like 3 to 10 day interval that you were there, and they put you on this regimen to get you out of that hospital, to get you, to feel better. And now that you are, now the room is open, it's handed over to your primary doctor to reassess. Same thing happens at nursing homes. They have a different formulary, so they might change, hold, adjust the medications, expecting things to be in a certain way. Some new medications may be started if you had a heart attack or you were diagnosed with heart failure. Then you come back with new medications. But remember, they leave room for you to change them, reassess, and so they're passing the baton. And so don't always feel that everything has changed 180. It looks like it, but for the most part, what's really happening is the doctors are passing the baton over and expecting and assuming that these things can be resumed, adjusted, changed, or stopped based on that. And if there is any medication that is like significantly different or now not necessary, then there's usually a reason that your doctor will be able to identify, whether it's through review of records or some information that's passed on to them. So keeping that in mind, I think it's very important for you to share. One is see your primary doctor as soon as you get out of the hospital. Call them, make an appointment within the first week, go see your doctor, and have your medications reviewed. Besides taking the paperwork, I think take all the medications that you have on hand. And the first list is the medication that the doctor prescribed. If my patient is coming back to me, then this is the 5 medications that I want you to be on. These are the names, and this is what you want. Then the second list is the medications that are actually dispensed by the pharmacist, because between me prescribing a certain medication and the patient getting that medication, a lot can change, because the insurance steps in and says, yeah, you might be right, but we're not paying for this. Pick an alternative. Sometimes the insurances will just say, we're not paying for this, we'll need a prior authorization, or just stop it. It's too expensive, we don't want to pay for it. We don't want to pay for it. They tell you other things, but the bottom line is that they say, oh, we don't want to pay for that. And a lot of times we just say, okay, the alternative is equally good, so you can switch them over to that medicine. But then this is not the written list that I gave you. Now, when the pharmacist dispenses that list of medications, so that's list number 2, which may or can differ from the original list that I have with me, or your doctor has with you. And then the third list is, what are the medications that you are actually taking? The patient believes that, okay, I want to take that. I'm surprised that a lot of patients will carry all the medications with them, but not take all of them. They feel that this blue or the yellow pill gives them, makes them sleepy. And and then they look at the side effects list, and they'll find the common ones that are the symptoms that are common for pretty much every medication. They say, oh, okay, so I was right, that this medication is making me feel like that, and then they're not taking that. So the third list is basically what are the medications that the patient is actually taking. Some of them they're not taking, some of them they ran out. The prescription ran out, or the reason is the insurance never paid for it. So we have to compare the list that the doctor gives out, the medicines that the pharmacist actually dispenses, and the medications that the patient is actually taking. For whatever reason, whether they ran out, or they found it too expensive, or they don't like the taste of it, they find that the pill is too big, pill is too small, it's made in a certain way, or this is not the same brand as they used to take and doesn't make them feel right. Whatever the reason is, we like to confirm what their list is. And now, after the hospitalization, we're adding in at least one more list that's coming from the hospital, which I usually see it as a guide for me to, okay, this is more or less the same medications. This was started, so why would this have been started for this patient? It's not that hard to guess or figure out, and after review of some records and all that, it's fair to see that what they were doing. So keep that in mind. It's very confusing. The best way would be that you have, like, this is your list, this is the pharmacy's list, and this is my list. And my list means what I'm actually taking. It doesn't matter if I have all the bottles or not. I have to all the time, like, show them that, are you taking this? Are you taking this? And every now and then, like every now and then means every fourth patient will say, no, I'm not taking those two. I'm just taking the other three. And then we got to identify the reason. So what you can do is make sure you take all your bottles, all your medications, supplements, vitamins, things that you bought from Amazon, GNC, Vitamin Shop. Take everything with you, put them in a bag, and dump them in the doctor's office. Let them review it and compare it, and that's the best way. And do not hesitate to say that why you don't want to take a certain medication. Most of my patients will tell me, oh, can you take out a few? Or, rightfully so, nobody wants to be taking 8 medications every day. Or they'll say that, this is too much medicine. Fair enough. And then we go over the medications and we review. Can we take anything out? Because the goal is to be on the least amount of medications for the most effect. Sometimes it's possible. Sometimes we do take out medications, and sometimes, unfortunately, you have to add more because I'm not even getting the effect that I want, the results or the outcome that I want, even with those 8 or 9 medications that you're on. So we have to add them. But what I want from you as a patient is to share what's stopping you from taking these medications. What is your belief and what is your fear of taking these medications? Because once that's clarified, things become a lot easier. It becomes much simpler, much easier, and much more useful. Your visit will become much more useful. Your doctor will get to know you and probably work with you and try to find a reasonable alternative if there is one. And if there's not, at least he can educate you that why you're taking what you're taking. So it's very important that you do that. Just add some comments what you liked about this, what you didn't, so that I can improve on my future discussions. And if there are any topics that you want me to talk about, I prefer questions, because the questions that you will have will pertain particularly to you, so I'll try to give you a more specific answer. but surprisingly, there'll be hundreds of people who have the same question. We're living in the same healthcare environment, and most of the things that are confusing for you are probably equally confusing for a lot of other people. So thank you for your time, your attention, and your feedback. I really appreciate it, and I will see you next week. Thank you.